pH, while ascending limb thick one, it helps us to maintain the level of salts, glucose, urea, water, and other minerals granular filtration composed by water, iron, and small molecules, while PCT, it reabsorbs sodium, chloride, potassium, water, glucose, amino acid, bicarbonates, calcium, and phosphate. It secretes ammonium and creatinine. While thin descending limb of loop of Henle, it reabsorbs water. The thin ascending limb, it reabsorbs sodium and chloride. The thick ascending limb reabsorbs ammonium and sodium chloride, while collecting tubules, it reabsorbs sodium, chloride, and water, secretes ammonium, hydrogen, and potassium, and the distal convoluted tubules that reabsorbs the sodium and chloride. Now coming to the juxtaglomerular apparatus, it is the final part of the ascending limb of loop of Henle. It is mainly in the cortex region, and it has an afferent efferent arteriole of its own at the globulus. This contains the macula densa, which is a specialized cells, and this is in the distal It has got arteria, afferent arterioles, kernel cells. Again, this is a specialized cell, and this is going to be in the afferent arterioles that secretes the renal. You can see the cortex and medulla, and one can see the juxtamedullary membrane where it is situated. Coming to the glomerulus and Bowman's capsule. Now, this lies within the cortex of the kidney. It consists of the afferent and efferent arterioles, and which is going to control the ultrafiltrate of the plasma. This passively lets the water and amino acids, sodium, and other free ions to pass through its membrane and into the tubular system. But it does not allow the charged proteins and large proteins of the cells. And this is very important in certain diseases when we deal with the anesthesia part. The unique basement membrane, it is at the interface of the capillaries and Bowman's capsule. And this is the main thing which allows and permits the glomerular.
Madam, no audio.
The slides are also not moving.
Madam, we can't hear you. Sorry for the technical issues. We will be back soon. Sorry, madam, we are not able to hear you or see you. Even the slides are not moving. Now I am seeing the kidney slide with the two separate kidneys each with one fibrous capsule. No, ma'am. No, madam, it's not moving. Network. Hello, madam. No, madam. It's that Dr. Talika has started screen sharing. Double click to enter full screen mode. Madam is.
Sir, I'm doing screen sharing. I've opened up everything.
Okay, now I can see you, madam. Now your video is coming and audio is coming.
Yeah, but can you see the slide sharing? Wait a minute. Are you presentation? Can you see it now, sir? Yeah, desktop se kar rahe hain. Can you see the slide moving now? Yeah. So when I'm going to the full screen mode, you are not able to see. What should I do, sir? Tell me. Pardon, sir? It is laptop only, sir. It is laptop. I'll go to the full screen. Wait a minute. Okay. Can you see now, sir? It is full screen. Can you see it now? Okay. Just a minute. Slide share. So what I'll request you is, can you take up the case? By that time, I will call the IT person and I will get it done, sir. Yeah. You please go ahead with the discussion.
Sorry for the technical glitches. To fix the glitch, we need some time. So during this time, I request Dr. Hemlata Kamath, Dr. Samir Desai, Dr. Navina, and Dr. Aditya to come over and continue with the case discussion.
Okay, good afternoon, everyone. Hemlata ma'am.
Good afternoon. Yeah.
Yeah. Aditya, you can unmute yourself.
Yes, sir.
Good afternoon,
sir. Good
Good afternoon.
Okay, let's straight away start the case presentation and then we will follow it with the discussion.
So can you enable screen sharing, sir?
Yes.
પછી તો શું કરે છે આને સ્લાઇડ શો કરવા માટે અહીંયા કરે છે સ્લાઇડ શો
હા મેમ F5 દબાવીએ એટલે સ્લાઇડ શો સ્ટાર્ટ થઈ જાય અહીંયાથી કરવી તો અહીંયાથી પણ થાય
મારે બતાવતું કેમ નથી
Aditya, try to share the slides.
Sir, actually, ma'am is sharing the.
પ્રેઝન્ટ ઓનલાઈન થશે ને હા
Okay, otherwise,
You have to stop sharing the screen.
પાછું લોગિન
Ma'am should stop sharing the screen, sir.
પેલા આઈટી વાળાને બોલાવી
Tarlika
પણ
ma'am,
નથી આવતું ને એનું શું કરીએ
you need to mute
કેમ
the.
કે અહીંયા તો જો બતાવે છે કે the slide is being shared
Tarlika ma'am,
અહીંયાથી મેમ કરતો હશે એવું હશે
Okay, Tarlika.
Now you can share the
તમે આ
screen.
પ્રેસ કરો તો અહીંયાથી
Okay.
હા
કેમ
એવું
કે
હોઈ
આ મેં
શકે
પહેલી વાર
Screen,
જોયું
yes, please go ahead.
આવી રીતે અહીંયા નીચે હોય છે
હા હોઈ શકે
પછી
Good afternoon, everyone. Today we'll be presenting a case of acute kidney injury. So, a 32-year-old male patient by name Vittal Sadashiv Madapagol. He hails from Athani as a teacher by occupation. He presented with complaints of fever since 7 days and pain abdomen since 5 days. So the patient was apparently all right around 1 week back when the patient developed fever, which was sudden in onset, progressive in nature, and continuous and high grade, which relieved on medications and was not associated with chills and rigor and no diurnal variation. The patient also developed sudden onset of pain abdomen since 5 days, and it was excruciating, diffuse, sharp, non-radiating, and severe abdominal pain. It was not associated with the distension of abdomen, vomiting, diarrhea, hemoptysis, and hematuria. And the patient was diagnosed with typhoid fever 6 days back and was treated with IV fluids, antibiotics, and antipyretics. The patient does not have any previous history of surgeries. The patient is not a smoker or an alcoholic. Sleep has been decreased since last 3 to 4 days because of the pain. He takes mixed diet and appetite has decreased. There is decreased urine output and he did not pass stools in the last 3 days.
Coming to general physical examination, the patient is moderately built and nourished, and patient looks anxious and uncomfortable. The weight of the patient is approximately 60 kgs and height is 170 centimeters. He does not have any pallor, icterus, cyanosis, or edema, and the spine is normal. Vitals, his heart rate is 115 beats per minute, and the pulse volume is feeble with regular pulse. BP is 90 by 60 millimeter per mercury in supine position measured in the right upper limb. Respiratory rate is 22 cycles per minute and SpO2 is 95% in the room air. Systemic examination per abdomen on inspection, there is no distension of abdomen seen, no engorged veins over the abdomen and no visible peristalsis seen. Palpation, tenderness is present, it is diffuse all over the abdomen and guarding is present. There's no rebound tenderness, no palpable mass felt, no rigidity, and no aortic pulsations felt. Percussion, there is no dullness on percussion, and auscultation, there is absent bowel sounds. Respiratory system, bilateral air entry is equal, no wheeze or rhonchi heard, and no basal crepitations heard. CVS, S1, S2 are heard, and no murmurs heard. CNS, if the patient is conscious, well oriented to time, place, and person, there's no motor or sensory deficit. Airway examination, teeth intact and there's no loose teeth present. Jaw movements are adequate. Mallampatti grading is 2, and neck is the normal range of motion, and thiomental distance is 3 fingers. Beard is present. On evaluation by the surgeon, the hollow viscous perforation is suspected, and X-ray erect abdomen shows the free air under the diaphragm. CT scan also shows the suspected hollow viscous perforation. Patient was posted for the emergency expiratory laparotomy and proceed. The provisional diagnosis is a young adult male with acute abdomen, probably a hollow viscous perforation, posted for emergency expiratory laparotomy and proceed.
okay. Hemlata ma'am.
So, yeah, what are your concerns in this patient? Can you enumerate whatever concerns you feel when such a case comes to you?
Yes, ma'am. Ma'am, this case is posted as an emergency case, so proper optimization of the patient will not be there. Also, this patient presented in the casualty with poor hemodynamic status with tachycardia of 115 beats per minute, and tachypnea was also there, and Also, his BP was on the lower side, around 90 by 60 millimeters of mercury. So this patient with also diagnosis of a typhoid, there is a possibility of a hollow viscous perforation. He can be in shock also, in septic shock.
Yes.
So the first thing to be done is resuscitation of the patient in the casualty. So the first thing to do is proper IV fluid administration for that resuscitation in order to maintain the vitals of the patient. And later on,
Aditya, not
yes,
the
sir.
management. Ma'am asked just the concerns. What are all the concerns? You said septicemia, hemodynamic instability.
Yes, sir.
So further, what all the systems can be affected?
The other systems include the renal systems, the kidneys, because of the constant hypertension, the patient, the hyperperfusion to the renal organs can be there. Also, the cerebral perfusion may be less. Also, the patient can have infections of the lungs and all. Pneumonia may be there because of the sepsis component. And the patient can also have
Patient can go into multi-organ dysfunction,
multi-organ dysfunction
because of
also.
the full-blown sepsis.
You said his look is also, he's not looking very well. No, he's
Yes,
looking anxious and he's tachypnic and he's sort of a toxic look. So
Yes,
he's probably in impending septic shock or SIRS. He's already into that inflammatory process.
Yes,
right?
ma'am.
So regarding that, how will you prepare this patient?
So how
Or
are you going
optimize?
to go about this case?
First, the resuscitation of the patient should be done in the casualty as soon as the patient comes.
Yeah.
So we'll start on IV fluids, IV fluid resuscitation, and we'll
Which
see the
IV
response. We'll start with NS, normal saline, 0.9% normal saline. We can start with normal saline, and later on, if needed, we'll switch over to renal lactate.
Okay.
So we'll be giving a fluid bolus around 30 ml per kg, and we'll see the response to the blood pressure, and accordingly we'll proceed with further management.
You started IV fluids, but what is the overall management? This patient has come now posted for emergency laparotomy.
Yes, sir.
So how are you going to go about it? Are you going to ask investigations?
Yes, sir. We'll start with
What
investigations.
investigations you want? Yep.
First of all, a CBC, sir, hemoglobin, because this is a major surgery, exploratory laparotomy. We'll need to know the hemoglobin of the patient along with the platelets and the total leukocyte count. So the sepsis component, to know the sepsis component, and further serum electrolytes, sodium, potassium, because the patient was dehydrated, and also the patient.
He said he's not eating for so many days, no? Some 3
Yes,
4
ma'am.
days he's not had any.
Yes, ma'am. Also, the blood sugar we will see, ma'am. On presentations of a blood sugar be done now, so that if the patient is drowsy also, so he can be hyperglycemic also.
Okay.
Later on, we'll go ahead and we'll ask for a blood urea serum creatinine to see if the kidneys are involved, and because he has a history of decreased urine output also.
Okay.
And
patients of sepsis, renal
renal,
involvement.
yes, sir.
And LFT,
Also
sir.
the LFT, sir, because LFT, sir, to see if any hepatic involvement is also there, and we'll also get an ABG done to see if the patient is in acidosis, because if you're suspecting any acute kidney injury or dehydration, something like that, if the lactate levels are rise, so to know that, we'll get an ABG done. Other than that,
cardiovascular system, the heart, how you want to evaluate the heart? You said about
We'll
the liver, about the kidney. What about other major organs?
we'll get an ECG done,
ECG.
and ECG will show any rhythm abnormalities of anything. Also, will
Coagulation profile.
coagulation profile also, to see if any coagulation abnormalities are there in the patient.
But coagulation profile, you exactly tell me. You have to say what investigation.
We'll be getting a platelets, the PTINR and the APTT, and also the bleeding time and the clotting time.
Bleeding time, clotting time are
Because
not very reliable in a patient
Yeah.
with sepsis.
Nowadays, we are not going for bleeding and clotting time much. We see the INR and the
INR,
APTT.
APTT.
Right?
The
Yeah.
bleeding time will be severely affected when the patient's is hemodynamically unstable. The perfusion to the skin is not reliable. All right. So bleeding time will not be reliable, especially in a perioperative setting in a patient of sepsis. So PTA, PTT is a most standardized. Okay.
What about the chest X-ray? You want
Chest
the
X-ray?
A chest
Yes.
X-ray, it was already done because they were suspecting intestinal perforation, and they found free air under the diaphragm. So the chest X-ray will ask for chest X-ray if it is not done.
Okay. Saturation was 95%. You said.
Saturation was 95% on room MR.
So,
In
so
the
when you start,
sorry. Yeah.
sorry. So when you start IV fluids, you can also start oxygen, no?
Yes.
Yes.
As a part of a resuscitation when you see the patient in the emergency room.
Yes, ma'am.
Okay. And also probably any other things, any other procedures you would like to do besides starting IV fluids, giving oxygen?
We'll put a central line if needed, and
Central line.
we'll also yes, ma'am, central line and an arterial line can be put in order to see the.
Do you want a central line? Right
Ma'am,
away?
if the fluid resuscitation is not adequate, then we'll have to start vasopressin, ma'am. So in order to do that, a central line will be better, ma'am. And if they're suspecting hollow viscous perforation, and if the patient is being taken up for laparotomy, a central line would be better, ma'am, because the patient would need antibiotics and other IV medicines for the next maybe 5 to 6
Which other
days.
IV medications? Central line administration.
Ma'am, vasopressin, ma'am.
Yeah, vasopressin.
Vasopressors and maybe potassium in the future.
Potassium.
I don't know the investigations, but vasopressors and potassium if it is necessary. Otherwise, only for volume resuscitation, which one is better, central line or the peripheral line?
The peripheral line is always better.
So yes, you can choose for central line if you are not able to access a good peripheral IV access. But in an emergency setting, actually you can start off the case with a good peripheral line.
You can start a wide bore.
Wide bore,
line.
16
Yeah.
inch IV can.
And he's a young fellow, right? 32-year-old. So probably not that, not having a lot of comorbidities. You have not mentioned any, at least in the history.
No, he doesn't have any comorbidities.
So probably just a peripheral line wide bore, and then after you shift him in the operation theater, probably under USG guidance and all, you can put a central line there.
Yes, sir.
Can you show the slide of investigations? What were the investigations for this patient?
One more thing before you shift him to the operation theater. Anything else you would like to do in this patient before you see him in the operation theater?
Yeah.
We'll confirm the.
You have started a big bore IV cannula and maybe oxygen.
Yeah.
Anything else rather than central line?
An arterial line, sir.
In an emergencies in casualty setup, what is the first thing that you want to do?
We'll place a Foley's catheter, sir, and a nasogastric tube, especially, sir, because we are suspecting
when you are telling that the patient's urine output is less,
urine output is also less,
and you are giving a fluid bolus, you want to assess the patient's urine output.
Yes.
Okay, and then it's a emergency laparotomy with acute abdomen. You need to decompress. It's a suspected hollow viscous perforation. You need to decompress the stomach.
Yeah.
For that, the Rice tube, gastric tube, and aspiration. All right. In the ABG, particularly, what values are you looking concentrating?
So in
what
the
is
ABG,
the relevance?
In the ABG, we'll be looking at the pH values, whether there is acidemia or alkalosis. So if there is acidosis, we'll be looking for whether there is any metabolic acidosis. The lactate values also will be saying so, because the patient is in sepsis. If it is more than 2 millimoles per liter and all, we'll have to start thinking about correcting it. So
it basically indicates global hypoperfusion and the overall prognosis. Okay, the severity of your cirrhosis and the cause of acidosis gives you overall prognostic indicator. All right. So you have decided the patient. In the previous slide, you showed the creatinine to be quite high, 2.8, and bilirubin also to be slightly deranged.
Yes.
So now you have got few hours time. The laparotomy you cannot delay it for many hours. At least few hours time. What are the things you are going to optimize?
First, we will optimize the intravascular volume status, sir, by giving a goal-directed fluid therapy, sir. We do it by targeting the we aim at least a systolic blood pressure of 100 mm Hg, sir, and urine output of at least 0.5 ml per kg per hour. And we also see for the signs of dehydration, sir, if any, to know the intravascular volume status. And
Dehydration, like?
Sir, excuse me.
Which signs of dehydration are you?
Which includes the patient appears thirsty, sir, and patient appears either irritable or lethargic, and urine output further decreasing and concentrated urine output.
Right.
Eyes and skin turgor.
Where else you look for the signs of dehydration in an adult? First is a symptom. What about the signs? Where will you look for the signs of dehydration?
The oral dry tongue.
No, tongue. Yeah. Okay, then continue.
The skin turgor, sir. We can check for the skin turgor.
Okay.
And the mental status of the patient also, sir, whether the patient is confused or lethargic or irritable or calm. That also tells the sign, status dehydration.
So you started off with a volume resuscitation with a sodium chloride. Now you got the blood investigations with the creatinine of 2.8 and the potassium of 4.4, and you got all these investigations. You are given about say 1 liters of normal saline. Are you going to change anything now?
We can change the fluid from normal saline to something balanced salt solution like a renal lactate, which will prevent hyperchloremic metabolic acidosis associated with the normal saline. And because his potassium values are within normal limits, RL is fine for him.
Okay. So you mean to say that excess volumes of normal saline infusion can itself lead to hyperchloremic metabolic acidosis. And why is hyperchloremic metabolic acidosis bad? What way it affects?
It can itself cause acute kidney injury.
Yes,
it is a poor prognostic factor for
renal vasoconstriction, and it can lead to decrease further worsening of the acute kidney injury. Okay, so balanced salt solution may be a better resuscitation. Having said that, initial volume of resuscitation, initial fluid of resuscitation can be normal saline. All right. Okay. So now you are taking the patient to the operating room. How are you going to go about it? What monitorings are you going to use? Yes, ma'am. Just
to complete a list of investigations, since it's for exploratory laparotomy, I think one more investigation in terms of blood grouping cross matching.
Yes, ma'am.
Needs to be sent just to complete the list.
Yes, ma'am.
Okay, continue. Your shift, as sir said, now the patient is shifted to the OR.
So, in the
what is your plan of anesthesia? What monitorings you are going to use? What drugs are you going to use? Quickly.
We plan for general anesthesia with placing the epidural catheter, sir. We decide about the activating the epidural. We can decide about the activating with epidural later after depending upon the patient's hemodynamic stability, sir. But because coagulation profile is also fine, INR is fine, so is slightly 1.4. You can go ahead with epidural with GS. Then the standard.
This is a septic case, right? You're suspecting a septic shock. So placing an epidural at this stage, you can probably
will not be activating.
No, even if you don't activate it, any unnecessary interventions, I think, should be avoided at this stage at least. I think, I don't know what Dr. Samir Desai.
Yes, I also agree. Basically, your patient who is in a septic shock, you are unlikely to use it during the surgery as well as post-operative period. You can consider the other multimodal analgesia options rather than the epidural. And per se, yes, of course, it's a major surgery with a quite significant amount of pain, but the other nerve blocks you can consider at the end of surgery, which can avoid neuraxial hypotension associated with a neuraxial block. Okay.
It becomes a sort of a relative contraindication. In presence of any sepsis in the body, you should avoid central neuractions.
All right. So you have decided on general anesthesia. What monitoring are you going to use?
Standard monitoring, sir. First is the pulse oximetry to monitor the saturation, and we go ahead with invasive blood pressure monitoring, sir, by placing the arterial line. Because than the non-invasive, the invasive gives us a chance to monitor the hemodynamic status, especially intraoperatively. The aggressive hemodynamic monitoring is essential for such cases. So we will get to know the pulse pressure variability, which is a more reliable indicator. And the other monitor which we attach is ECG, and the end-tidal CO2 concentration we monitor, and the temperature monitoring, and hourly urine output monitoring, and neuromuscular monitoring. These are the monitors which we are going to attach.
One more thing, intra-arterial monitoring, considering this case, who's not so bad, and you already started with the fluid resuscitation and probably started getting urine output also. I mean, I'm just hypothesizing. So right away, whether to put an arterial line, yes, it will give you an idea for sure, but you can at least wait for some time. Intraoperatively also, you can put it. I mean, that's what, I mean, it's an invasive procedure, and a lot of things have to be kept in mind, cost factors, everything. So right away, putting an intra-arterial line in this case, I mean, because your case is not so bad, is not requiring inotropes right now at least. Was he on inotropes during induction when you did the case?
When we did the case, he was on noradrenaline.
Already on noradrenaline when you
Yes,
started the case? Okay.
Yes, ma'am.
So then probably you are just, yeah.
Yeah, one more thing in the pre-op process, 1 hour when you had a time for resuscitation, one more investigation yourself can do if the setup permits, or you can take the help is ultrasound for IVC collapse.
Yes.
That you can use it to assess the fluid volume resuscitation status. If you have that, if you have adequately resuscitated the volume pre-operatively, then no point giving excessive fluids. In that case, you have to go on the vasopressors. Okay. If you do not have a expertise for ultrasonography for IVC compressibility or other signs, then maybe, as ma'am said, again it depends upon many factors like your setup and cost and affordability and many other things. But if it is all those things are available, ideally you can go ahead with a patient who is on a vasopressors. You can take a invasive blood pressure line under local or immediately after induction. But it is desirable, if you are definitely going to do it just before the induction, because most of the hypotension happens immediately after the time of induction. Okay. So, and what is the relevance of beat-to-beat monitoring of hypotension? Why you want to do that?
So to avoid transient falls in BP cell, because in patients who are prone for
this patient has got already existing organ hypoperfusion with a damage like AKI. So you need to maintain the perfusion pressure very aggressively. Otherwise, even brief periods like 10 to 20 minutes of hypoperfusion can lead to worsening of the AKI. That's the reason you have to be like monitoring, aggressive monitoring and aggressive treatment. Aggressive treatment doesn't mean that you have to do OSULSA extra. You will get a goal-directed therapy. This will also help. Okay.
Non-invasive BP monitoring is also good enough. So you can initially try these things, then going for invasive ultrasound to check the IVC compressibility, and then non-invasive BP monitoring with a timer at every 3 to 5 minutes will also help you. So as far as possible these days, we are going for non-invasive more than invasive. That is the reason I'm saying. But yes, if you have all the facilities and you have the skills and all, cost is not a factor, you can go ahead.
Okay. So how are you going to induce anesthesia? And once you have you got arterial line, how are you going to assess the fluid status with arterial line?
We'll be using the pulse pressure variability for assessing
under anesthesia.
Good
Okay.
response.
So
Yes, sir.
what is the desirable pulse pressure variation? How will you interpret that?
So if it is more than 12%, then it is a sign of hypovolemia, sir.
Okay. Almost 10%. So you adequately hydrated patient will have a less pulse pressure variation. All right. Okay, go ahead with the anesthesia.
So we'll be going ahead with, we'll be starting with pre-medications. We'll be starting with injection glycopyrrolate 0.005 mg per kg and injection midazolam 0.05 mg per kg and injection fentanyl IV around 3 microgram per kg will be giving. And later on, once we go to the induction agents, we'll be choosing etomidate 0.3 mg per kg. And we can go with the short-acting muscle relaxant like succinylcholine because its potassium is 4.44. We can give around 1 to 2 mg per kg is succinylcholine. And once the patient is intubated, sir, and he's put on the ventilator.
Wait. What is the method here? What is the
Rapid? We'll be going with the rapid sequence intubation now.
Yes, this is an emergency laparoscopy.
With
So
pre-oxygenation.
can you explain what you mean by rapid sequence intubation?
Ma'am, rapid sequence intubation is done whenever there is an emergency, ma'am, where the patient is not adequately nailed by mouth, ma'am. So, and in pregnant ladies also, we go ahead with the rapid sequence intubation.
Even if this patient is adequately nailed by mouth for the last 2 days, any acute abdomen, you have to do rapid sequence.
Yes.
Okay, go ahead.
Exactly the steps of rapid sequence intubation.
When we'll be going ahead with pre-oxygenation, ma'am, we'll be holding the mask and 100% oxygen, and we'll be giving a pre-medication like glycopyrrolate and or atropine, and we'll be giving it this etomidate or propofol or thiopentone as an induction agent, ma'am, along with the short-acting muscle relaxant like succinylcholine, ma'am. Once the patient is once we give the short-acting muscle relaxant, we'll be holding the cricoid pressure, ma'am. We'll be giving cricoid pressure around 30 newtons cricoid pressure will be giving. That is to prevent any regurgitation from the esophagus, ma'am. It will just occlude the esophagus, ma'am. So once that is done, we'll be intubating the patient, ma'am. And once the patient is intubated, we'll be releasing the cricoid pressure, ma'am.
No, you should not relieve the cricoid pressure before inflating the cuff.
After inflating cuff, ma'am.
Yeah. So your cricoid pressure will be released only after you inflate the cuff.
Yes, ma'am.
So that is how you are making it foolproof for aspirations, right? Okay.
Yes, ma'am.
Go ahead. So you have the endotracheal tubing.
Maintenance of anesthesia with the?
We'll be maintaining with an oxygen nitrous combination in with an inhalation agent like sevoflurane or isoflurane.
Nitrous oxide again in a.
Nitrous oxide we'll avoid, sir.
You can avoid, yeah, many places.
What will you use instead?
Instead, we'll use air, ma'am.
Okay.
So isoflurane and muscle relaxant, what are you going to
Muscle relaxant will be using atracurium, considering his creatinine is 2.8. We'll be going ahead with atracurium.
What FiO2 you want to keep?
Around 50% FiO2.
Okay. Fine.
and
And
use
what,
peak if possible. Use of peak.
Yes, sir.
inhalation agent you mentioned?
Ma'am, we'll be using sevoflurane, ma'am, or isoflurane.
Okay, and you're practicing low flow or what is it?
Low flow anesthesia.
Low flow.
Yes,
Okay.
ma'am.
Okay, fine.
So this patient had a pre-operatively itself the creatinine value of 2.8 and to some extent the acidosis 7.3 or something. The acidosis was there. So what do you think? What was the possible reason for renal involvement in this case?
Sir, in this case, because of the persistent hyperperfusion, because of the low systolic blood pressure, and because of the sepsis component, both would have caused acute kidney injury. There will be a prerenal involvement as.
Hello.
Hello. Hello.
Aditya, we cannot hear you.
I think there was a problem with the internet.
Oh.
Aditya?
No, they are not responding. It's hanged. Can you hear us?
Yes, ma'am. Sorry,
No.
sorry, ma'am.
Yes.
Okay, why the renal involvement in this patient? You were telling. Yes, continue.
Yes, sir. One is the persistent hypertension because of the persistent hypoperfusion because of the hypertension in the patient, as well as a sepsis component. The cytokines and all that can cause a direct tubular injury. So there is a pre-renal cause and as well as renal cause causing the acute kidney injury. So.
Okay. As you said, it is a pre-renal component, that is the hypoperfusion of the organ, renal kidney. But per se, that itself doesn't explain all the extent of AKI. There is a renal injury also directly by the endotoxins, inflammatory mediators, TNF-alpha, and many of the other things, which are directly nephrotoxic. They produce a vasoconstriction. Okay. So how to, already there is some degree of damage which has happened. How are you going to prevent further damage and try to resuscitate? This AKI, can you, do you know what is this AKI and severity? How do you grade it? What is AKI first of all?
AKI is nothing but the it's an abrupt decrease in the function of kidney, sir, which results in the accumulation of all the nitrogenous waste products which are supposed to get excreted. So it is reflected by increase in the serum creatinine and urea, and also decrease in the urine output. So this is a staging, that is kidney disease improving global outcome staging. There are 3 stages where the stage 1 says there is increase in the creatinine of 1.5 to 1.9 times the baseline, or there is increase of more than or equal to 0.3 mg per deciliter of creatinine, and also the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours. In stage 2, there is increase of 2 to 2.9 times the baseline, and the urine output is less than or equal to 0.5 ml per kg per hour for more than 12 hours. In stage 3, there is increase of creatinine of 3 times the baseline, or increase of serum creatinine to absolute value of 4 mg per deciliter, or there is a requirement of renal replacement therapy. And coming to the urine output, there is decrease in the urine output of less than 0.3 ml per kg per hour for more than 24 hours, or there is complete anuria for more than 12 hours.
So there are about 3 to 4 components in your definitions, that is staging. One is absolute value of creatinine, which has increased. Second one is, if you have a baseline, then how many times it has increased. That is the second component. And per se, creatinine alone is not enough. Urine output. Urine output is also taken into the consideration. Okay, but only urine output also is not reliable. Ultimately, creatinine value is taken as a surrogate marker of severity of renal function, decrease in the renal function. And the fourth component in this definition is hours. That is over how much period of time. Right? So basically you are trying to see how much decrease in the urine output. Urine output per se, only one parameter is not sufficient to make the diagnosis of AKI. The reason is
especially in this patient in the perioperative setting, surgical stress and all, they'll release ADH and even this thing, hypovolemic episodes will be there.
It can exist in many other conditions, like perioperative setting. Why in perioperative setting the urine output tends to be lower? Even in a normal patient, who doesn't have any renal problem, many of the patients we see, the urine output tends to drop.
So because of the release of ADH by the surgical stress.
Yes.
The stress of the surgery, the pain and all, the surgery.
As a stress response to surgery, body tends to retain water. Many of the hormones which are released as a stress response, they tend to retain water especially up to day 3, and that produces water retention and less urine output perioperative. So it is urine output per se is not specific. Then creatinine, what is why not absolute value of creatinine? Only one value of creatinine taken as a diagnosis. Like value of 1 up to 1.3 is normal, 1.3 to 2 they have not given like that. Why it is compared to the baseline?
Because creatinine can vary, sir. It depends upon the age, sex, and even the body muscle mass of the patient, sir. So we cannot standardize the absolute value of creatinine, whereas the actual increase or decrease, that is the trend of the creatinine, is more accurate than the absolute value of creatinine.
Yes, that's why
it is not very specific.
Baseline is very important for some frail 70-year-old lady. Even 1.3 value of creatinine may be already doubled. Actually, her baseline may be something like 0.7. For her, if the 1.3 value, if you see first time, it may already be doubled. Okay, and when will the creatinine tends to rise? That means if the creatinine is increased, what does it mean? Does it mean that it's an early injury, or
how good a marker is it? How good a marker
has already happened, and there is always a delay for that insult to be reflected in the creatinine value, sir. Usually around more than 2 to 3 days, the delay is there, sir.
The rise in creatinine is observed once almost 50% of the glomerular function is declined.
It is almost 50% of the GFR is reduced.
So it is not a very reliable marker for early detection.
Early detection. It is not for early detection
of kidneys compromise that is occurring. So urine output as well as creatinine are not very good.
Hello.
Yes.
Okay. So
you don't have any baseline of the patient, right? He came with a creatinine of 2.8.
Yes,
so we don't know what his baseline was. And 2.8 is definitely above the normal range. So yes, he's already come in a compromised state.
Yes, ma'am.
That's the reason
so
in the KDIGO they have included more than 0.3 milligram per deciliter increase in the creatinine, even after, if it is after admission, whatever the value, if the increasing trend in the creatinine, then that signifies worsening AKI status, or more than 4 milligram per deciliter of absolute value, that definitely means that severity. So creatinine, both the value is important as well as trend is important. Okay. All right. So why is creatinine taken as a marker? Why is it is the creatinine per se very harmful for the body? Why are you measuring the creatinine again and
Sorry,
again? When the creatinine
disconnected.
Yeah.
Hello.
Why are you measuring creatinine again and again? It's a normal protein in the body, in the muscle. Is it harmful for the body?
Sir, first thing, when the creatinine is raised, it tells us that the kidney function is deranged, sir, which means the glomerular filtration rate is decreased, sir. So there is
it correlates very well with the renal function, glomerular GFR, okay, effective GFR. Can you roughly tell me how to calculate GFR with a serum creatinine value?
Yes, sir. The formula is 140 minus age into weight of the patient by 72 into serum creatinine, sir, for males, and for females we have to multiply it with 0.85.
Okay.
It tells us that.
There are many formula, but this one is fairly commonly used. You should be knowing. And as I said, for a 70-year-old frail female, if you 50 kilo female, if you even with the serum creatinine value of 1.3, it will come to somewhere GFR around 40, which is kind of already the renal functions are affected. Okay, so you know this patient is got a acute kidney injury. Previously we used to call this renal failure. We no longer use the word renal failure for such cases. You know why?
So because this is a multisystemic disorder, sir. So this AKI, it can involve other systems of the body like this CNS, the hepatic system, the lungs, even the cardiac system also. So that is why it is known as the acute kidney injury, sir.
And also it has a spectrum of disease where it is reversible if it is treated and detected early, sir. Whereas the previously it is called as acute renal failure, but it's not a failure per se, it's the impairment of the functions.
Yeah. It's not that because it affects many organs, it has to be, should not be called as failure. Even the liver failure affects many organs. Okay, that is not the reason. Affecting other organs is not the criteria, but the failure is just all organ. It's like an end stage. But before reaching the end stage, there are various grades that, of dysfunction. That's why it is called as acute kidney injury, not like a complete failure. And number two reason, as she said, is when it is treated well, diagnosed and treated well, this failure can be reverted. So it is not a failure. Okay. So it is more of graded. All right. So how are you going to diagnose and manage these patients to prevent further injury and to revert whatever the injury which has happened?
First thing we should intraoperatively we monitor the early urine output, sir. It tells us if the AKI is worsening or not.
No, agreed. Urine output monitoring has to be done hourly, but is the urine output going to give you a full information? I mean, suppose
no.
what is the cutoff point where you will be worried? Say how much ml per hour you want. 0.5 ml per kg per hour. If you're getting this person is how much? 50 kg?
60
kg.
60 kg. So if you're not even getting 20 ml per hour, are you worried?
Yes,
ma'am.
So how will you go about investigating this? Will you take it at face value, or you want to check it out whether it's a real urine output or there is something is hampering the collection or whatever? You are seeing only less than 20 ml per hour in the Euro bag, right? So how will you go about now checking?
First, we'll check the patency of the urine catheter, ma'am. Sometimes, most of the times, when the patient is positioned or draped, there is a chance that the tube gets kinked. So and we don't actually see the urine output, but the urine output is there.
Yes.
Then, but still, if the urine output is not present, adequate urine output is not present, then we think of that the patient either is in hypovolemia or hypotension. We check, so that we can
hemodynamics, whether it is with that urine output. Okay. Yeah. So you improvise on your hemodynamics. Okay, give IV fluids, start vasopressors, all that. Okay.
How much fluid are you going to give? Of course, hypovolemia to be treated. So you keep giving fluid 500 ml per hour? Yes.
No, ma'am. No, sir. We can give fluid challenge, sir, for at least for 3 times. And if the patient is still not responding, then we can start on inotropes, because both the hypovolemia at the same time hypervolemia is also deleterious for the kidney.
Why is hypervolemia deleterious?
Because any causes like any pre-existing heart conditions or liver failure or
this is a
heart failure.
30-year-old boy. He doesn't have any renal cardiac failure. Even then, hypovolemia is bad for kidney.
Hypovolemia also causes increase in the venous congestion, which again is deleterious for the kidney. So it again leads to the
venous
tissue hypoperfusion.
The organ perfusion is arterial pressure minus the venous pressure. And if the venous congestion is excess, whatever reason, then that effective organ perfusion decreases. So what is your target mean arterial pressure?
So we'll be targeting a minimum mean arterial pressure of 65 millimeters of mercury, which is sufficient for renal perfusion, sir. or
systolic blood pressure of 80 to 100, sir. At least
Which
the
is
auto-regulation.
You mean to say why 65 is sufficient? You are telling?
So because the auto-regulation of the kidney, it varies from 80 millimeters of mercury to around 180 millimeters of mercury. The mean arterial pressure ranges is that. So we'll try to maintain it around 65 to around 80 millimeters of mercury, sir.
Yeah, 70 to 170 PSI. So if the pressure is less than 70, then the renal perfusion start decreasing. That's the reason you maintain at least 65 to 70 millimeters of mercury pressure.
Yes.
This patient is not a hypertensive, chronic hypertension. Otherwise, the patients who are on chronic hypertension and not well controlled, there the auto-regulation will be set at a higher level.
Yes.
And then even you have to be careful about your.
So do not say that 65 is enough in everyone. Okay.
Yeah.
It depends upon their baseline values. Okay. In a healthy young patient with no other comorbidities, yes, 65 is a minimum target you should aim. Why? What happens if it falls below 65?
The first, the auto-regulation is failed, sir, and upon that there is a tissue hypoxemia. So there is because of hypoperfusion of the kidneys. So and it further leads to acute tubular necrosis because of the hypovolemia and hypoperfusion.
Not necessarily acute tubular necrosis. It worsens the AKI.
Worsens.
Even the brief periods of hypoperfusion during the surgery are known to worsen the AKI severity. Okay. So how much period? Having said that, many a times we see quite a lot of hypotension happening during the induction. As I said, during the immediately induction or sudden blood loss, sudden fluid loss, many causes there will be hypotension. Even for 1 or 2 minutes hypotension, you'll be worried. How are you going to worry?
Even like hypertension for 5 minutes, sir, with mean arterial pressure of less than 60 is deleterious.
To say 10 to 20 minutes with a less than 60, and 5 to 10 minutes with less than 55 mean arterial pressure is shown to be deleterious. So if you are given hydration, and then if the pressure is still less than 65, what is your next line of management?
We'll start on inotropes, sir.
Which inotropes?
I mean the adrenaline, noradrenaline. We start noradrenaline infusions.
Why is that?
Because noradrenaline acts on both alpha-1 and beta-1 receptors, sir. So it causes arterial and venous constriction. At the same time, it increases the contractility of the heart, sir, which is.
Are you not worried that it is an alpha-1 agonist which will cause a renal vasoconstriction? In general, vasoconstriction. Will it not reduce the renal perfusion?
It reduces if we are not, or we have not given the fluid at all, sir. When we have given fluid and again starting the noradrenaline, then it wouldn't cause much of renal damage.
Okay, there may be decreased renal perfusion. Okay, but thing is the value gained by increasing the mean arterial pressure is outweighs the risk of increasing the renal vasoconstriction. Effectively, there is a increase in the blood flow. Okay, when your primary target should be mainly the MAB. Increase the MAB, rather than worrying about you're causing alpha-1 vasoconstriction. Which should I go for noradrenaline? Should I go for dopamine? Should I go for other? How about dopamine? Previously, they used to use dopamine.
Previously, they used to use low-dose dopamine for renal protection, sir. But now that concept has changed, sir. The studies have told it is no longer a renoprotective, sir. Because
it further causes hypotension, sir, along with the
hypotension, the low dose.
Okay. Low dose.
The low dose. What is low dose dopamine, which was described? That was in a healthy volunteers, where it improved the renal perfusion. But in a scenario of sepsis, when the patient has already adrenergic surge inside, endogenous adrenergic surge, in such an intense situation, the low dose dopamine is not going to be helpful as a renal vasodilator. So your aim is primarily targeting the MAP rather than worrying which receptor to act on and which this one. You mainly maintain the high perfusion pressure that will take care of the renal perfusion. Okay.
Moreover, this renal perfusion you cannot measure clinically, whereas MAPs you can monitor, right? So they are more objective.
Even just after induction, you are not prepared noradrenaline infusion yet. There is a hypotension. What are you going to use?
Using a phenylephrine, sir.
Yeah, phenylephrine. Again, do not worry too much about which agent are you going to use. Use faster, whichever is available, and maintain the MAP. Okay. And if it is sustained for quite some time, use an infusion of noradrenaline, preferably. All right. Okay. So your volume resuscitated. Again, you are using crystalloid, intraoperative,
yes,
not colloid or blood or anything.
Yes,
What about colloids? What is the take on colloids in such cases?
Colloids, they themselves are a cause of AKI, and they can actually worsen the acute kidney injury present in the patient. So as of now, crystalloids are better than especially starch, hydroxyethyl starch. Yes. So as of now, crystalloids are the preferred resuscitation fluids now.
How about blood?
Blood transfusion can be given if their blood transfusion is itself a cause of AKI, but still it can be given if there is excessive bleeding, ma'am.
Because as per the demands, that is, as per any other case, you target the hemoglobin and look at transfusion trigger like any other disease, like any other condition. Per se, giving transfusion is not going to help kidney either oxygenation. All right.
It might in fact damage because of the inflammatory reactions and all. And if this patient, God forbid, goes forward in the CKD or something, then again it will be a problem. So it should not, we should not give blood as far as possible.
Okay. How about you are not seeing the urine output for quite few hours? Then how about giving the dose of furosemide or Lasix or other diuretics?
Sir, routine use of diuretics is not recommended, sir, until and unless we suspect any volume overload, sir. So before giving diuretics, we first have to see the see if there's any volume overload, like we auscultate the chest and see if there's any pulmonary edema. And even because the patient is under GA, we can see the plateau pressures and then decide on giving diuretics. But routine use
there is a hypervolemia.
Hypervolemia.
Yeah.
Why not give routinely the furosemide?
Routine furosemide, when given, especially given in the large doses, sir, it causes hypotension and again decreases the perfusion, sir, to the kidneys. And also the furosemide increases the renal tissue oxygen demand, sir. So it further damages the kidney.
Oxygen mismatch. It increases the oxygen demand in a kidney where already there is a depletion of oxygen. Okay, so it can worsen, and doses, if at all useful, are quite high, like 1 to 1.5 mg. 5 mg, 10 mg, what we many times use is not does not produce any beneficial effect. Okay, if at all you are using it, should be for hypervolemia. Right. So maintaining the global perfusion, that is intravascular status, MAP, and anything else are you going to do?
Yes, we avoid other nephrotoxic drugs, sir, which again worsens the condition. Like anesthetic drugs, which include the morphine, pethidine,
pethidine, tramadol, and also.
Okay.
And,
are these nephrotoxic?
They are not nephrotoxic.
They are not nephrotoxic. They are metabolites and nephrotoxic.
Yeah, but
the metabolites
get nephrotoxic. Not nephrotoxic, ma'am. Their metabolites will cause neurotoxicity and seizures and all. In the case of they're not eliminated.
Their metabolism is affected in AKI. They are per se not nephrotoxic. Okay, their metabolic.
They will have a delayed action. Even the metabolites are active, and they will have a delayed action recovery from their effects.
So, which are the nephrotoxic drugs you want to avoid?
NSAIDs, sir, and antibiotics like aminoglycosides and amphotericin B.
Why
And
is that? Why NSAID are nephrotoxic?
Because sir, it inhibits the prostaglandins. Sir. So that what happens is there is inhibition of the renal vasodilation. Sir. So at the efferent end of the at the efferent end of the renal arteries, what happens is there is a decreased blood flow, sir. So
the protective mechanism of vasodilatation, which is caused by prostaglandins, is inhibited by NSAID.
Yes. So
Which
even a
causes-
single dose of NSAID can tip the patient towards a worst grade of AKI. Totally avoid even the single doses. Then you said aminoglycosides are nephrotoxic. What are the drugs?
Any other drugs which patient can be subjected to perioperatively?
During the perioperative period.
Radio contrast dyes.
whether the patient.
Yes. Contrast-induced nephropathy is also common. That is also directly nephrotoxic. Okay.
Suppose a patient has to undergo, not this patient, but suppose a patient has been given some radio contrast and comes for anesthesia. How will you manage in terms of prevention of AKI?
Will be
Will
Contrast-induced renal damage, how to avoid? Ma'am is asking.
fluids.
Yes. Rehydration.
Hydration is most important.
Hydration.
Next.
Any other?
Yes.
And
N-acetylcysteine.
N-acetylcysteine. Okay, you can give it over a period of 12 hours before. If you know this patient is going to undergo immediate surgery, you can start it 12 hours before, along with the hydration. So that will help the patient. Okay.
So you have taken these precautions during the surgery, and most important, because sepsis, as you said, was the cause for the renal injury. Primary intention is to treat the sepsis. That's why the source of infection in this case is acute abdomen. So you have to do the surgery, and you have to give a good perioperative antibiotic cover. All right. That is also very important for control of sepsis. You don't look only kidney. You have to treat the underlying cause, which is a sepsis. And then, how are you going to do the? Okay, the patient is, the surgery is over. What are you going to do with this one? Extubation. Where are you going to keep the patient? What are you going to do?
Patient is still on adrenaline. Patient is still on adrenaline. How was your patient when you conducted this case?
Patient was on noradrenaline intraoperatively, ma'am.
Okay.
Post-operatively, on day 2, they started titrating.
So how did you manage this patient at the end of the surgery with noradrenaline?
We continue noradrenaline infusion, ma'am.
So it was ongoing, right? So
Yes.
how did you reverse this patient?
Ma'am?
Did you reverse this patient?
No,
No,
ma'am. We did
patient
not
was-
reverse the patient.
Okay. So
Patient was kept on mechanical ventilator, ma'am, in the ICU.
Okay. Okay. So how was the post-op?
And on day 2, patient was extubated.
Day 2 he got extubated. Okay.
Yes, for day 2, after ABG after titrating the noradrenaline and after the patient is properly stabilized, then the patient was extubated.
So you have any investigations of the first day in the ICU, second day? How was the creatinine?
Ma'am, creatinine was around 2.8, ma'am, initially, and later on it was around 2.2 on day 1, ma'am, after the morning of the surgery, and later on day 3 it reduced to 1.6, ma'am.
Okay.
So the trend was decreasing.
The trend was a decreasing trend.
So that is important because you're not only this adrenaline, but overall the biochemistry also should improve. It should respond to antibiotics, accounts, everything you have to see in the ICU, not just the tapering of the noradrenaline.
And serum lactate level and the severity of acidosis.
Yes.
Those should be decreasing. Okay. Serum lactate, you should concentrate from the preoperative period to assess the hydration status. Again, the adequacy of tissue perfusion. Okay.
How did you manage the analgesia part? You had an epidural catheter in your patient?
Yes, ma'am. For this patient, Yes, ma'am.
You had placed it pre-operatively before
Yes,
inducing.
ma'am. Before
Okay.
inducing.
But you could use it intraoperatively or
No, ma'am.
No, ma'am. Intraoperatively, it was not used, ma'am.
okay.
Post-operatively, still the patient was on noradrenaline
Right?
on day 1.
Yes, ma'am. On
Could
yes,
you
ma'am.
use?
Yes,
Oh, no, sir.
no, sir. We couldn't use.
That's why most ma'am was telling that
That is why
for such patients you may not be able to use the epidural infusion. Okay. So what are the analgesia options for this patient?
When they, at the end of the surgery, we can try out facial plane blocks. The basic transverse abdominal plane block can be given, sir. And along with that, we can give IV opioids and IV analgesics like paracetamol can be given to this patient. So we'll focus on multimodal analgesia for this patient, ma'am. So
opioids,
this
what
will,
opioids to give?
we'll be giving fentanyl, ma'am,
So
which
as
will
in-
also help in maintaining the sedation in the ICU, ma'am.
Yeah, okay. And you gave paracetamol
Yes, ma'am.
and tab block.
Yes,
Bilateral tab blocks. Okay.
Bilateral transverse abdominal plane block.
Okay, fine.
What is likely to happen for the AKI overall? AKI, this patient, other than cardiac, most of the other investigations were fine, and patient developed AKI. Is it likely to change the outcome of the patient, prognosis of the patient?
So it can, AKI always leads to increased hospital stay and mortality in the patient, sir. So
Ventilator, ICU days, all that is going to increase. And inpatient hospital 30-day mortality is likely to increase. And many of
they
them
can progress
to CKI.
AD if
Yes.
So we talked about the various factors which can predispose to AKI, the medical problems. What about the surgical conditions?
ma'am, especially the AKI is most commonly seen in cardiothoracic surgeries, ma'am. Around 30% of the cardiothoracic surgeries where there is involvement of aortic clamping and all, it can progress to acute kidney injury, ma'am. Among the general surgeries, ma'am, the massive peritoneal surgeries, ma'am, they are cause of acute kidney injury, ma'am. They can lead to acute kidney injury.
Laparotomies, laparoscopies also, as well as you said, CPB, particularly cardiopulmonary bypass, induces a lot of inflammation and post-operative AKI, and hepatic transplant, renal, of course, renal transplant, but even the hepatic transplant, there's a lot of hypoperfusion for kidney during the perioperative period. Many surgeries are
vascular surgeries, surgeries, transplant surgeries, even gastric bypass, bariatric surgeries. They are more likely to develop AKI in the perioperative.
When you basically the focus is more on aggressive identification and maintaining the goal-directed therapy for the hemodynamics. It is more of septicemia management also, and aggressive monitoring and early intervention treatment. Prevent further damage. That's all. You cannot per se treat. If you prevent the further damage, the renal functions are likely to recover if it is in the early stage of sepsis. If it is already very late stage of septicemia or underlying cause is already caused significant damage, then the chances of them proceeding to the CKD is there. Okay. Okay. You want to add anything, ma'am?
No. So basically, your patient had a component of sepsis which made him go into AKI, right? So which are the other predisposing factors? Just if you can enumerate. Your patient, it was sepsis. But which are the other predisposing factors for development of AKI in abdominal surgery like this?
Any pre-existing comorbidities like hypertension, diabetes, and elderly patient, ma'am, and female gender. All these are predisposing factors, ma'am. And also
already existing preoperative renal disease also.
Yes, ma'am.
Is a yeah. Besides your hypertension, diabetes, age, and even patients having any LV dysfunctions.
Yes.
Obesity, massive blood loss during the surgery.
Yes. Severe hypotension during intraoperative period, either because of blood loss or because of fluid mismanagement. So these can also make them go into AKI. So this is not just it is a multifaceted problem. So you have to be always having a high degree of suspicion. Okay.
Thank you, Dr. Aditya. And Dr. Sripal, I think the time we run out of time.
Yeah, that was a good presentation. Yeah, good effort by both of you.
Both of you. Thank you. Dr. Navina and Dr. Aditya, thank you.
Yeah.
Thank you, sir.
All the best.
Thank
for
you.
your
Thank you.
final exams or university exams.
Dr. Sripal? Sir?
You have lost all of them. Hello.
Hello. Yeah. Thank you very much for this elaborate and very good discussion on perioperative renal failure, acute renal failure. It's very, very elaborate and very interesting. So we had very good insights. Thank you, Dr. Hemlata and Dr. Samir, and Dr. Aditya and Dr. Navina. Actually, they prepared very well and presented excellently.
Yes.
Thank you so much.
Thank you, sir.
I really appreciate your time and commitment for this. Thank
We
you.
also enjoyed. Thank you.
Enjoyed.
And we regret the technical glitches during this presentation. As and when we have more technology involved, I think these kind of problems are more likely to be there.
So is Tarlika going to be there?
Madam has said that she has got another engagement at around somewhere after 5 o'clock.
Okay,
So she had to stay back.
okay.
I again thank Dr. Tarlika also. And I request now Dr. Guru Prasad, consultant anesthesiologist and intensivist at Gadag, to present instrument of the month, that is Cricothyrotomy.
Okay.
Dr. Guru Prasad.
Can you allow me to share my slide?
Yes, please. Yes, you have been made a co-host, so you can present.
I'll just.
In between, there is a question by Dr. Rajesh. Dr. Rajesh, good afternoon. The question is dose of N-acetylcysteine for preoperative renal protection. Dr. Hemlata or Dr. Samir, you may please answer this question. Dr. Hemlata, madam, you are muted.
Can you hear me now?
Yes, yes, yes.
Yeah, I also have not practiced giving N-acetylcysteine, but the literature says that it is about 600 milligrams 3 to 4 times a day, and it has to be started 12 hours before. So suppose you have planned your patient for some radio contrast studies, radiological imaging, and that patient is going to be posted for some elective surgery. You see that at least you get 12 to 24 hours before, so that you can hydrate him well and give this dose 12 hours before. Only then it will help. Otherwise, it will not help.
Yes, we do use it for few patients of ICU when we know that their renal function is already this one, and they need contrast study. As ma'am said, usually more important than N-acetylcysteine is again hydration. So you hydrate the patient well, 100 ml to, like 100 ml per hour, at least for 10-12 hours beforehand. And usually you start N-acetylcysteine 600 mg. We usually give 2 doses before the radio diagnostic procedure. 600 mg 12th hourly, 2 doses just before the procedure. The evidence may not be very strong for N-acetylcysteine, but it is protective mainly by acts as a reducing agent.
Yes.
Thank you. Is this presentation seen?
Yes, yes.
Presentation is seen, madam?
Yeah, your screen is seen. Cricothyrotomy.
Yeah. Okay.
Is seen.
Yeah, thanks, Dr. Rajesh, for your support all the time you are with us. And before I invited Dr. Guru Prasad, I want to welcome my teacher, Professor Dr. N.V. Nagalakshmi, who is there in the group. Thank you, madam, for being attending this program. Your presence is a blessing to us. Over to Dr. Guru Prasad.
Yeah. Actually, good afternoon, Naglakshmi madam. It is a pleasant surprise that you are amongst this participants. And I think till I knew that you were not there, I was comfortable. Now, knowing that you are here, I become more jittery, madam. Anyhow, with your blessings, you have come up in our life. And I'll start my presentation on cricothyroid equipments. At the outset, I thank Kshema for giving me this opportunity to present on this topic. Cricothyrotomy, as all of us know, we anesthetists should be proudly called as airway consultants. And when it comes to airway, you should not go in search of any surgeon or an ENT surgeon. It is we who have to manage the whole thing. Okay, that confidence you have to get by the time you finish your post-graduation. So,
sir, just a minute. Can we see your video?
Acha, 1 minute.
It will be nice seeing you talk rather than just.
Okay, I'll see whether I can do that.
Yes, sir. I can see you here.
But I think one of the things can, because I'm doing it on a MacBook, on an iPad, I think only one thing can be seen, madam.
Oh, okay, fine then.
Okay. So cricothyrotomy, cricothyrotomy. So basically, it is a surgical way of accessing the airway in a can't intubate, can't oxygenate scenario, which is encountered after you've seen that your advanced airway management or non-surgical upper airway techniques have failed to restore oxygenation. So basically, it is an emergency procedure which has to be done to secure an airway, which is temporary till you get your and a definitive airway. So this is the anatomy what we are looking for. So this is the thyroid cartilage. Then this is the cricoid cartilage. I think you can see it, na? And the avascular membrane between the thyroid and cricoid cartilage is a cricothyroid membrane. So whatever I'll be talking in the next few slides will be based on the entry of the airway through this route, that is through the cricothyroid membrane. So straight away coming to equipments. So this is the first equipment, set of equipments I would like to show. It's a traditional surgical cricothyrotomy set. So what does it contain? It has a scalpel blade, a tracheal hook, a tracheostomy dilator, an endotracheal tube, or a tracheostomy tube. And how do you do the procedure? You take a small nick over the cricothyroid membrane. So how do you identify? You have to run your finger from the thyroid cartilage downwards, and the first dip you are going to get is a cricothyroid space, or the and there's where the cricothyroid membrane is. So this is the place where actually you have to enter. So once you take a nick on the cricothyroid membrane, you use the Proceus dilator to widen the access, and then under vision you insert either an endotracheal tube or a small size tracheostomy tube to secure the to do a cricothyrotomy. So next is a Rush patented quick track. So this is nothing but a needle or cannula technique. What you have here, I think you can see here, these are the commercial kits available. So it is there is a needle over which the cricothyrotomy tube is there. So it is a needle and cannula kit. So you have got two lengths, that is 20 millimeter and 25 millimeter. Probably an obese patient, you may have to, obese patient, short neck, you may have to go for a longer needle. And what you do is, again, you identify the cricothyroid space, then take a small nick, then using a water-filled syringe, with the cricothyrotomy set, you enter the cricothyroid space. Then once you start aspirating air, like how we do when you do a percutaneous tracheostomy, that time you know that the tip of the needle is in the trachea, and then you slide this outer cricothyrotomy tube into it, and that's how you do cricothyrotomy with a quick track set. This piece of equipment which you can see is an extension tube which will help you to give enough distance to connect the ambu bag or your circuits to ventilate the patient.
Guru, your audio is not coming. Guru, we can't hear you.
So we are not hearing anything.
Dr. Guru Prasad?
It's stuck, I think. Maybe you need to call him directly.
Yeah. Not able to hear it, Dr. Guru Prasad. This one is
Recording in progress.
I think I can be seen now.
Yes.
Seen and heard. Okay, I'll share the presentation. Till what slide didn't you hear me? Where was that?
Now you can see the slides.
Okay, 1 minute. No, till which I was explaining this.
Sir, I think number 6. Number 6 you had just completed.
This one?
No.
Or this one?
Number 6. Yes, this one.
Okay.
Yeah, you are there. Yes.
Okay. Did I complete this?
We couldn't hear you all throughout.
Okay. The previous one was okay, no, madam?
Yes.
This was okay.
Yeah.
Okay.
Yeah, this was fine. Now you are explaining the Melkar.
Okay.
Yeah.
So you can see me also, I think now.
Yes, sir.
Yeah. This is a Cook patented Melkar cricothyrotomy set. Okay. Where it is basically you use a Seldinger technique for that. Okay, with the Seldinger technique, you try to secure the airway. So you are provided with a guide wire, a syringe, a knife, a needle with cannula, then the cricothyrotomy tube with the trocar, which will be used as a dilator too. If you can see the shape of it, it is that like a sequential dilator type of thing. So what initially you do is you take a small nick again on the cricothyroid membrane, then you use the needle to enter the trachea. Once the trachea is entered, then you get air bubbles in the syringe. Then next you pass a guide wire through it. Then using the cricothyrotomy set, which is a self dilator, you enter the trachea, then pull out the cannula. So that is how you secure the airway with the Melkar cricothyrotomy set. So next is a Portex patented emergency cricothyrotomy set. So this has got a bit of different technique to secure the airway. So in the kit you get a knife blade, a syringe, then a jelly, and this patented cricothyrotomy set. So the trocar of this cricothyrotomy set is somewhat similar to the Viris needle we use during the laparoscopic surgery to do pneumoperitoneum. Whenever it hits against the resistance, you see this red indicator coming out. Okay, so that whenever this red indicator is seen, that tells that the needle is facing or come across some resistance. So basically, you identify the cricothyroid membrane, then take a nick. You can hear me?
Yes.
Yeah. Then you use the cricothyrotomy set to enter the trachea. the moment the needle gets the resistance, you can see this indicator is seen. Actually, it is a red color to be seen. So this is seen. So that tells that there is some resistance. The moment you enter the trachea and the needle is released, the red indicator disappears, telling that there is no resistance in ahead. So once you get into the trachea, what you have to do is you have to proceed still further till you hit the posterior wall. The moment you hit the posterior wall, again, because of the resistance, you get this indicator. Then you have to move the needle chordate, then slide the cricothyrotomy tube into the trachea, then pull out the trocar. So that is how you do this, do a cricothyrotomy using a Portex set. Next is a pulsatile needle cricothyrotomy. Okay, here this uses the technology or technique of jet ventilation. What you have done here is you are using a 14 gauge or the biggest cannula possible. You have entered the cricothyroid membrane. You attach a three-way here. Then use a tube to connect it to the wall oxygen outlet, and you keep the flow as high as possible. Okay. Then you intermittently keep on using your thumb to close this port of the three-way, so that whenever you close, the air enters, and when you release, there is expiration. So this is how you use the pulsatile needle cricothyrotomy set for cricothyrotomy. And as I said, most of these once you secure airway with the cricothyrotomy, it is just temporary, and you have to look out for a permanent airway access. So this is another device which is called as a live stat, and it is a keyring device. So this is basically been devised to be used by even a lay person if he sees some patient who's got an upper airway obstruction. So it is a set wherein there is a sharp trocar over which you get a cannula. Okay, you use this set, and probably when it is an outside a hospital airway obstruction, you don't get a knife to. I think you have to just enter the through the cricothyroid membrane straight away, and then pull out the cannula, pull out the trocar, and that is how you secure the airway with this type of keyring device. This piece of equipment is a universal adapter. What you do is, once you the cannula is within the trachea, you connect this to this end, and it just gives an extension for you to connect it to an ambu bag. Okay, then this is one thing which we routinely keep it in our OT, thickest possible needle with you, with a syringe and connector of an endotracheal tube, which is connected in this way, and this can be connected to the ambu bag. So similarly, once all these things are ready, because we have to keep this set ready and stuck to the wall. I have tried on an just an false alarm and trying to collect these three things. It took me at least 8 to 10 minutes to get all these devices in one place. So in a situation of can't ventilate, can't oxygenate, 8 minutes is too long a time. So if you keep such sets ready in your operation theater or in your emergency ward or in any ward for that matter, what you have to do is just enter the cricothyroid membrane and connect it to an ambu bag, which will help you to ventilate the patient. You can use you can in fact also connect it in such a way that you can use a three-way and you can use it as a jet ventilator. This is one device I think which is really helpful to secure an airway. And as requested by Dr. Sripad Mendale, they told me that I can show one video on one of the techniques. So I chose this technique because all these things are easily available. The bougie is available, an endotracheal tube is available, and the scalpel is available. Unlike the previous few kits I showed of the Rouge or Portex, they are quite expensive, and this piece of equipment will do the same job what the other things do. So I'll just show you a video of the stab twist bougie technique. So what you have to have is a 10 number scalpel blade, a bougie with an oxygenation port, preferably with an oxygen port. You can see a small hole there which oxygenates the patient, and a 6 number endotracheal tube. And this is how you stand at the head end and try to shake hands or shake larynx with your right hand and try to identify the cricothyroid membrane. That is how he is trying to identify cricothyroid membrane. If it is an obese patient, I think sometimes you may not feel the cricothyroid membrane. So what you do is that time you take a vertical incision and dissect with your fingers or with the artery, and then you may feel it. But in a usually normal patient, you can feel a cricothyroid membrane. So you stab the knife in this way, okay, and then rotate the scalpel in 90 degrees so that the sharp end directs to the inferior direction. Okay, then you move the scalpel little lateral to make space for the bougie to enter into the trachea. Okay, this is how you push the bougie to enter into the trachea. Then a well lubricated 6 number. See this you have to always do. You have to pull and push the bougie to so that there is a free movement and you are sure that it is in the trachea. Then with a well lubricated jelly, the tube, you pass it. Here also you have to give a small nick as with the scalpel as shown prior. Then with the twisting movement, you have to enter the trachea. But all these techniques are easy said than done, because the panic will create a lot of anxiety and things may go wayward. Okay, and this is how stab twist bougie technique, bougie tube will practice. Okay, so this is a very practical one, and you should always keep an STBT set in your OT, and it is, I'm sure that this is a very easy way to secure an surgical airway. So my take-home points are simple. We anesthetists are always called as an airway consultants, and we have to justify for what we have called for. Since these procedures are done in emergency, you have to have a clear concepts about it. Don't try to practice this on an emergency patient. You have to do drills before on a mannequin about how you are going to do this technique. Always keep one set of cricothyrotomy equipment in the crash cart so that it is easily accessible. And try to understand, picturize, and practice one of the techniques perfectly so that it helps you whenever you need. So with this, I end my presentation. I put this thank you slide because if I am little late, the wave will come and will rub off that thank you which I have written on the sand. So if you want the patient to thank you, you have to act very fast and secure his airway so that you can oxygenate him and he is given an opportunity to thank you. Thank you once again.
Thanks, Dr. Guru Prasad, for this excellent presentation. As always, Dr. Guru Prasad does a wonderful job. Put all his efforts behind his whatever presentation or whatever he does. Thank you so much. Hemlata madam has something to say. You have to unmute, ma'am.
Please unmute, madam. You are muted. You are muted.
Sorry if I have not heard you correctly, but for this surgical cricothyrotomy, the patient has to be paralyzed.
Madam, this patient whom you are trying to do an emergency tracheostomy is already hypoxic and is listless. Okay, yes. This is probably the end point of
last attempt. Yeah.
Okay, according to your guidelines, I think when we studied, it was like no muscle relaxant. But when I visited, I have not been practicing much of anesthesia recently, but courtesy Sripad, I get invitations in Kshema, and I update my anesthesia techniques there. And there I heard that the newer guidelines suggest that you have to use a muscle relaxant even in a difficult scenario, which is absolutely right, because we lived in a time of only endotracheal tubes, red rubber endotracheal tubes and all. Now, yeah, madam, especially this patient who is going to come, and when you are trying to do a front of this surgical airway assessment, because of hypoxia is already gone. This is the last resort you are trying to do to secure an airway, and you can just tap the neck and do it. I have done it. I have done it on a Ludwig's patient, which was referred from our side. Now I do more of critical care, so we get such patients. The patient came, but unfortunately the patient died. He was almost gasping when he entered the casualty. I could secure the airway, but I couldn't do much about it. He died. But STBT is one thing, because all the parts or the equipment like bougie, tube, and knife is easily available. And if it is kept in one box, name it as STBT and keep it in one box, I think definitely in a 25-30 year practice, you will use it only once, and that patient will definitely survive.
I just wanted to make it clear because there are many postgraduates, so I thought it's a part of the algorithm. So I should be, this should be given as a message to them that though the patient is hypoxic, might be limp, but many a times hypoxic patients are aggressive and they're moving a lot. When you're using a stab knife and all, it can be dangerous, especially in the area of the neck.
Yeah.
That is why I thought I should. The patient has to be extended. Yeah, the neck has to be extended. Somebody has to stabilize the head to keep it neutral. And then with a muscle relaxation on, this procedure can be done very fast. Yes, Dr. Shripad, am I right?
Yeah, thank you so much. Thanks for these comments. And I thank Dr. Guru and Dr. Hemlata for this good discussion. And if Dr. Talika is there, you may please join us, ma'am. I think Talika madam is a bit busy. If she can still join us, you are most welcome.
Sripad, any comments from Dr. Nagalakshmi madam?
No, I think madam has not commented yet.
She is on mute.
So we can personally clarify our matters with the madam, because madam is a bit wary of our technology.
Okay.
Easily understandable. And thank you so much for joining us, Guru, in spite of your busy intensivist and anesthesia schedules and your coaching classes.
Nothing.
So same with Dr. Hemlata, she is one octopus, managing a lot of things in the department and in the college. Thank you so much. Thank you, Dr. Samir, and our residents. Especially I have to thank Dr. Talika madam. She also put a lot of efforts. Unfortunately, technology was not in her favor today.
Hello, Samir.
Thank you, sir.
Samir, you can meet on anesthesia platforms.
Yes, sir.
Yeah, that's just 2 hours apart.
Yeah.
Yes, sir. 1 hour apart.
1 hour apart, yeah. Okay, so I think Talika madam has left the meeting. No problem. I just call upon my colleague, Dr. Rajaram.
Thank you, sir. Thank you for providing the opportunity.
Yeah, thank you so much.
Yeah, thank you. It was a pleasure.
Thank you so much. I'll call upon Dr. Rajaram to propose vote of thanks. Nagalakshmi madam is there. Madam, good afternoon and good evening. How are you? And we expect some words of wisdom from you.
Madam had just unmuted. Again, she's on mute.
Madam has to unmute. Hello, madam.
Did you hear me?
Yes, madam. Yes,
Yeah, madam. Namaste, madam.
It was a nice presentation. Yes,
Thank you.
In those days, people may remember that we used to keep 16 gauge needle with one endotracheal tube adapter.
Yes, madam.
Now cricothyrotomy sets have come, and also hooks there is there. It's it is not difficult these days to. Thank you. Okay.
Thank you, madam.
thank you, madam. Thank you. Thank you. Over to Dr. Rajaram.
Good evening, one and all. I, Dr. Rajaram Prabhu, would like to thank the organizing committee of Nitte Anaesthesia Education Series for giving me the opportunity to deliver the vote of thanks. I'd like to thank Dr. Tartika Parimal, Department of Anaesthesiology, Bairamji Jejibhai Medical College and Civil Hospital, Ahmedabad, for taking time off a busy schedule and for conducting the masterclass on renal physiology, relevant to anesthesiology. And we're extremely sorry for the technical issues related to the masterclass. I'd also like to thank Dr. Hemlata Kamath, Professor of Anesthesiology, Pramukh Swami Medical College, Gujarat, and Dr. Samir Desai, Professor and HOD of Anesthesiology, STM College of Medical Science, Dharwad, for moderating the case discussion on perioperative renal failure. I'd also like to thank Dr. Guru Prasad N, Consultant Anesthesiologist and Intensivist Gadak, for the excellent lecture on cricothyrotomy. Everyone has definitely gained the much needed knowledge. Thanks to you, sir.
Thank you.
I would like to appreciate the postgraduates, Dr. Aditya Sharma and Dr. Navina, for doing a wonderful job at the case presentation. I'd like to thank our wonderful audience for their participation and making this session a grand success. I'm grateful to Nitte University and EDP department for their enormous cooperation in organizing the event. I'd also like to thank all the faculty members of the Department of Anesthesiology, Kshema, who have worked hard for making this a successful session. Finally, I would like to thank Dr. Shripal Chithendra, who has been the backbone of Nitte Anaesthesia Education Series and has been making it a success for all the events. Lastly, I thank all of those who have directly or indirectly helped us in making this educational series a successful event. Thank you all.
Thanks, Dr. Rajaram. Thank you very much.
Thanks,
Dr. Anil as well. See you, everyone. See you again next month on 16th of June with another topic on renal physiology and renal derangement and anesthesia for renal cases. Thank you, everyone, again.
Yeah.
See you.
Thank you. Thank you.
My special thanks to our Professor Dr. Nagalakshmi. Thank you, madam.
Yeah.
Thank you. Bye-bye.